We are continuing the topic of inflammation, and today we will discuss three conditions: cystic fibrosis, pulmonary silicosis, and renal scleroma. One of defense mechanisms of normal lung is mucociliary escalator or mucociliary clearance that plays important role that allows to clean the air entering the respiratory tract. In normal circumstances, approximately 20 to 30 millimeters of secretions are produced by the airways on an everyday basis. These secretions, which are necessary to protect the airway from foreign particles, are cleared by the mucociliary escalator and swallowed. If the quantity of mucus exceeds this amount, a cough is necessary to clear the airways of the mucus. The mucociliary escalator covers most of the bronchi, bronchioles, and nose. It contains mucus-producing goblet cells and ciliated epithelium. The movements of the cilia push it, and anything in it, such as inhaled particles or microorganisms, up and down into the throat, which can either get swallowed or removed through the mouth. Cystic fibrosis is a disorder of epithelial ion transport affecting fluid secretion in exocrine glands and the epithelial linings of the respiratory, gastrointestinal, and reproductive tracts. The ion transport defects lead to abnormally viscid mucus secretions that block the airways and the pancreatic ducts, which in turn are responsible for the two most important clinical manifestations: recurrent and chronic pulmonary infections and pancreatic insufficiency. In addition, although the exocrine sweat glands are structurally normal and remain so throughout the course of the disease, a high level of sodium chloride in the sweat is a consistent and characteristic biochemical abnormality in cystic fibrosis. There is no exact document showing when the first clinical case of cystic fibrosis was identified. References have been found in medical texts as early as 1595, which linked salty skin and damage of the pancreas with death in childhood by infants who were hexed or bewitched. In this regard, Peter Paul performed the first autopsy of an 11-year-old female child in the anatomical theater in Leiden. He showed that the death was due to oddly swollen pancreas. Thereafter, in 1606, Alonso y de los Royes de Fonseca, professor of medicine at Henares in Spain, described the salty taste of infants with cystic fibrosis. In the mid-16th century, stearia was recognized as an indicator of cystic fibrosis. Moreover, Samuel Guy in 1888 reported digestive tract problems in cystic fibrosis patients, including arrest of growth, a distended abdomen, an attack of diarrhea with large, pale, foul-smelling stools. These symptoms were as a result of the injury and a clear change of pancreatic function. Furthermore, Landsteiner in 1905, who also has defined blood groups, published the report on association of Meconium ileus with defective cystic fibrosis pancreas. Later on, from 1930 to 1940, many findings were obtained about this condition. Indeed, the terminology of cystic fibrosis began to develop during the 1930s. During these years, the description focused on pancreatic disorders, stearia, and bronchopulmonary complications. Of this, Fanconi with co-authors in 1936 referred to the disease as cystic fibrosis with bronchiectasis and have separated it from celiac disease. Besides, in other work by Anderson in 1938, the term cystic fibrosis of the pancreas was used. Further, in 1945, Farber had introduced the term mucoviscidosis, state of thickened mucus that causes the disease, instead of what Anderson has proposed. This term still is in use in non-speaking English countries. As a matter of fact, first researchers who provided compelling evidence about source of cystic fibrosis were Anderson and Hodges in 1946. They reported cystic fibrosis as a genetic disorder as well as stems in an autosomal recessive mutation. In the next 6 years, Sant'Agnese from Colombia discovered the dissolution of salt, sodium chloride, as a disease index in patients with cystic fibrosis. Quickly, the sweat test became a most reliable diagnostic test to identify patients with this condition. However, to clarify the clearest criteria, both pathological demonstrations, such as abnormal thick or sticky mucus or proteinuria in the lumens of pancreas, lung, and intestine, and abnormal salty secretions of sweat glands are required. Further research revealed the differences in age and gender in cystic fibrosis. Generally, the incidence of this disease in children is higher than in adults. According to the published studies in European countries, there are approximately 4 children for every 3 adults with this condition. A study by McCormick and his co-authors showed that 53% of patients were under 18 years of age and only 5% of patients could survive over 40 of age. Although in Asian countries cystic fibrosis children are between 1 and 5 years of age, majority of them expired within first 5 years of their life. Besides the age, the gender was reported in correlation with cystic fibrosis development and survival. For instance, in an investigation conducted in Europe, the ratio of men with cystic fibrosis was 1.1 folds more than women. This means that about 53% of the reported patients in Europe were male. These results are widely acknowledged by other researchers. On the other hand, according to a study published in 1985 by Sturges, the cystic fibrosis development in Canadian men was 53.57% of the total population. In this regard, Dodge reported the survival rate of 55% for cystic fibrosis male patients and 49% for cystic fibrosis female patients. Moreover, the patients' data reported as 91% in 1988 and 88% in 1992. Furthermore, in 1997 it was 96%. The estimated cystic fibrosis population in the beginning of 2000s was 8,284 people. As shown in the previous studies, most of reported cystic fibrosis patients are children, and the frequency of infection in male is 6 to 8% higher than female subjects, and we can see that on the diagrams on this slide. To summarize and analyze various evidence-based research on cystic fibrosis, different public health organizations tried to launch a national level of cystic fibrosis registry. Among these organizations, there is Cystic Fibrosis Foundation in the United States of America, Canadian Cystic Fibrosis Foundation, United Kingdom of Cystic Fibrosis Trust, and Vancrella mucoviscidose can be named. Subsequent to these countries, many more cystic fibrosis foundations have been established worldwide. Finally, the International Organization for Cystic Fibrosis was formed in 1964 in Paris. Through this organization, various research activities, including pathological, molecular, treatment protocols, and epidemiological investigations, were established. At the same time, it must be remembered that cystic fibrosis can present with bewilderingly variable set of clinical findings. This variation in phenotype results from diverse mutations in cystic fibrosis associated gene, tissue-specific effects of loss of the cystic fibrosis gene's function, and the influence of disease-modified genes. Overall, there are more than 70,000 people who are living with cystic fibrosis worldwide. Approximately 1,000 new cases are diagnosed each year. More than 75% of the people with cystic fibrosis are diagnosed by age 2. With an incidence of 1 in 2,500 live births in the United States, cystic fibrosis is the most common lethal genetic disease that affects white population. The carrier frequency in the United States is 1 in 20 among Caucasians, but significantly lower among African Americans, Asians, and Hispanics. Cystic fibrosis follows simple autosomal recessive transmission, although even heterozygous carriers have a predisposition toward pulmonary and pancreatic disease at higher rates than general population. The primary defect in cystic fibrosis is reduced production or abnormal function of an epithelial chloride channel protein encoded by the cystic fibrosis transmembrane conductance regulator (CFTR) gene. Disruptive mutations in CFTR render the epithelial membranes relatively impermeable to chloride ions. In cystic fibrosis, a chloride channel defect in the sweat duct causes increased chloride and sodium concentration in sweat. Patients with cystic fibrosis have decreased chloride secretion and increased sodium and water reabsorption in the airways, leading to dehydration of the mucus layer coating epithelial cells, defective mucociliary action, and mucus plugging. On the pictures, the CFTR is the cystic fibrosis transmembrane conductance regulator, and ENAC is the epithelial sodium channel responsible for intracellular sodium conduction. However, the impact of this defect on transport function is tissue-specific. The major function of the CFTR protein in the sweat gland ducts is to reabsorb luminal chloride ions and augment sodium reabsorption through the epithelial sodium channel. Therefore, in the sweat ducts, loss of CFTR function leads to decreased reabsorption of sodium chloride and production of hypertonic or salty, quote and unquote, sweat. In contrast to sweat glands, CFTR in the respiratory and intestinal epithelium is one of the most important avenues for active luminal secretion of chloride. At these sites, CFTR mutation result in loss or reduction of chloride secretion into the lumen. Active luminal sodium absorption through ENACs also is increased, and both of these ion changes increase passive water reabsorption through the lumen, lowering the water content of the surface fluid layer coating mucosal cells. Unlike the sweat ducts, there is no difference in the salt concentration of the surface fluid layer coating the respiratory and intestinal mucosal cells in normal persons and in those with cystic fibrosis. Instead, respiratory and intestinal complications in cystic fibrosis seem to stem from dehydration of surface fluid layer. In the lungs, this dehydration leads to defective mucociliary action and the accumulation of concentrated viscid secretions that obstruct the air passages and predispose to recurrent pulmonary infections. In addition to chloride, CFTR also regulates secretion of bicarbonate ions. In fact, certain CFTR variants manifest only with abnormal bicarbonate transport, while chloride ion transport is largely preserved. Pancreatic insufficiency, a feature of classic cystic fibrosis, is virtually always present in patients who carry cystic fibrosis CFTR mutations with abnormal bicarbonate conductance. Since the CFTR gene was cloned in 1989, more than 1,800 disease-causing mutations have been identified. They can be classified on the basis of clinical course of cystic fibrosis, of the nature of the underlying defect. Mechanistically, they may result in reduced quantity of functional CFTR that reaches the cell surface, or reduced function of CFTR that reaches the cell surface. As we shall see, these differences impact on the development of treatment strategies. They can also be classified as severe or mild depending on the clinical phenotype. Severe mutations are associated with complete loss of CFTR protein function, whereas mild mutations allow some residual function. The most common severe CFTR mutation is a deletion of 3 nucleotides coding for phenylalanine at amino acid position 508. This causes misfolding and total loss of the CFTR. Worldwide, this mutation is found in approximately 70% of patients with cystic fibrosis. Since cystic fibrosis is an autosomal recessive disease, affected persons harbor mutations on both alleles. The nature of mutations on the 2 alleles influences the overall phenotype, as well as organ-specific manifestation. Although cystic fibrosis remains one of the best-known examples of the one gene, one disease axiom, there is increasing evidence that other genes modify the frequency and severity of organ-specific manifestations. Examples of modifier genes include mannose-binding lectin-2, MBL2, and transforming growth factor beta-1, TGF-beta-1. It is postulated that polymorphisms in these genes influence the ability of the lungs to tolerate infections with virulent microbes, thus modifying the natural history of cystic fibrosis. All officially recognized medical diagnoses are categorized in the International Classification of Diseases published by WHO, World Health Organization. The classification for cystic fibrosis is subdivided into 4 parts: cystic fibrosis with pulmonary manifestations, cystic fibrosis with intestinal manifestations, cystic fibrosis with other manifestations, and unspecified cystic fibrosis. Even classic cystic fibrosis can present with multitude of manifestations. Pancreatic abnormalities are present in 85 to 90% of patients. In the milder cases, there may be only accumulation of mucus in the small ducts with some dilation of the exocrine glands. In more advanced cases, usually seen in older children or adolescents, the ducts are totally plugged, causing atrophy of the exocrine glands and progressive fibrosis. On the picture, you can observe mild to moderate changes of cystic fibrosis in the pancreas. The ducts are dilated, and this is shown by the green arrows, and plugged with eosinophilic mucin. And the parenchymal glands, shown by the red arrows, atrophic and replaced by fibrous tissue, shown by the stars. The total loss of pancreatic exocrine secretion impairs fat absorption and may lead to vitamin A deficiency. This may contribute to squamous metaplasia of the lining epithelium of the pancreatic ducts, which may exacerbate injury caused by the inspissated mucus secretions. Thick, viscid plaques of mucus also may be found in the small intestine of infants. Sometimes this causes small bowel obstruction known as meconium ileus. The pulmonary changes are the most serious complications of this disease. On the picture are the lungs of the patient who died of cystic fibrosis. Extensive mucus plugging and dilation of the tracheobronchial tree are apparent. The pulmonary parenchyma is consolidated by a combination of both secretions and pneumonia. The greenish discoloration is a product of Pseudomonas infections. These changes stem from obstruction of the air passages by the viscous mucus secretions of submucosal glands and superimposed infections. The bronchioles often are distended by thick mucus associated with marked hyperplasia and hypertrophy of the mucus-secreting cells. Superimposed infections give rise to severe chronic bronchitis and bronchiectasis. Development of lung abscesses is common. Staphylococcus aureus, Haemophilus influenza, and Pseudomonas aeruginosa are the three most common organisms responsible for lung infections. Even more sinister is the increasing frequency of infection with another pseudomonad, Burkhalderia cepacia. This opportunistic bacterium is particularly hardy, and infection with this organism has been associated with fulminant illness, or so-called cepacia syndrome. The liver involvement follows the same basic pattern. Bile canaliculi are plugged by mucinous material accompanied by ductal proliferation and portal inflammation. Hepatic steatosis or fatty liver is a common finding in liver biopsies. With time, cirrhosis develops, resulting in diffuse hepatic nodularity. Such severe hepatic involvement is encountered in less than 10% of patients. Azoospermia and infertility are found in 95% of the affected males who survive to adulthood. Bilateral absence of the vas deferens is a frequent finding in these patients. In some males, this may be the only feature suggesting an underlying CFTR gene mutation. We're going to look at two pediatric cases of clinically confirmed cystic fibrosis that were referred for autopsy at the Department of General and Clinical Pathology at the University Hospital. The first case was a 1-year-old female and the second was a 6-month-old female. Both cases had classical cystic fibrosis associated growth changes in the lungs with cystic dilation of bronchi up to 1 centimeter. On histology, areas with lung parenchymal destruction, profuse polymorphonuclear infiltration, and dilated bronchi filled with slime-like detritus matter were clearly visible across all pulmonary sections. On the picture you see cystic bronchial dilation with a compacted matter in the lumen of the bronchi shown by the hollow arrow and inflammatory infiltrates in the alveoli shown by the black arrow. The liver in both cases was enlarged and yellowish in color with a distorted architecture of the cut surface. Histology revealed steatosis and cirrhotic changes. On the picture you see fibrosis in the portal area shown by the hollow arrow and steatosis shown by a black arrow. The pancreas during the investigation had cystic changes and histology revealed lobularization, and fibrosis with the formation of cysts and dilated intrapancreatic ducts. On the picture, you can observe cystic dilation of the intrapancreatic canals, shown by the hollow arrow, and fibrosis, shown by black arrow. Although grossly only hyperemic, the gastrointestinal system revealed surface epithelium erosions and severe inflammatory infiltrates in the mucosa, as well as thick viscous secretion in the glands. On the picture, you see thick mucous secretion in the glands, shown by the hollow arrow. The kidneys, although normal on gross inspection, also had severe changes on histology, with a compacted matter in the lumen of the distal tubules, some of which had undergone calcification. On the picture, you see compacted matter in the distant tubules, shown by the hollow arrow, and tubular calcification shown by the black arrow. The International System of Cystic Fibrosis are 65 roses, due to similarity in pronunciation. However, of the 6 organs, locations affected lung, liver, pancreas, intestines, skin, and kidneys, only 5 are discussed in depth in the scientific literature. The renal changes may trigger additional complications and exacerbate the course of the condition if misdiagnosed and untreated. Still, the renal changes, although often cited, are poorly defined in the literature, with the predominant dogma being that they also undergo cystic change, similar to polycystic kidney disease. As seen in these 2 cases, the changes, at least in the initial stages of the evolution of cystic fibrosis, do not result in cystic degeneration, but rather in distant tubule compaction and calcification, which with time may result in kidney failure, exacerbating the overall condition of the patients. The identical morphology present in both of the cases across all organ systems is key in defining the renal changes, not as incidental, but as associated with the pathogenesis of cystic fibrosis, albeit in an early stage. These changes may in time progress to the proposed polycystic-like morphology or be an all-separate morphological substrate of cystic fibrosis. Also worth noting is that these changes go hand in hand with the organ changes as seen by the age of both patients and do not represent a late complication of cystic fibrosis. However, the changes clinically may present as late complication, often attributed to multi-organ failure. This with time, and especially in patients where the overall condition is stable and susceptible to therapy, the described change may lead to chronic kidney failure as the leading cause of complications and hospital stay in cystic fibrosis. Cystic fibrosis is a relatively common genetic disorder with a wide spectrum of organic changes. If misdiagnosed and untreated, these changes may contribute to severe complications. The histological renal changes are underreported in literature, and thus, unlike the classical reported cystic changes, we highlight lumen compaction and calcification as a primary histological hallmark in kidneys of patients with cystic fibrosis. The second case report regarding the diagnosis of cystic fibrosis in a live patient was published recently in 2016. So let's have a look at it. So we're looking at the boy aged 18 years. He was presented to the tuberculosis clinic with a several-year history of chronically productive cough with associated shortness of breath and wheeze. He also reported of lethargy, night sweats, and weight loss. He also he had been screened for tuberculosis with a negative Mantoux test. 5 years previously. Owing to his ongoing symptoms, a chest X-ray was performed which revealed bilateral hilar lymphadenopathy, resulting in referral to the tuberculosis clinic. He was born in 2002 at 38 weeks gestation, and he was the fourth infant in the family. He had been fully immunized, including the BCG vaccination, and had no known tuberculosis contact. The only positive family history was of atopy. His parents report he developed a cough soon after birth, which persisted for most of his life. He was first acutely unwell with productive cough and weight loss at the age of 5 years old, and he was hospitalized and improved following a course of intravenous antibiotics. It was 3 years after the episode that he was started on asthma treatment following the development of a chronic cough. On initial examination at the tuberculosis clinic, his chest was clear on auscultation and he had several small submandibular lymph nodes. His height and weight were on the 9th centile for his age. Repeat tuberculosis investigation, including MAN2, T-spot, and sputum AFB, were negative. His sputum culture grew Staphylococcus aureus, and he was treated for a lower respiratory tract infection. At follow-up, he was still symptomatic with a chronically productive cough. And poor appetite. Further questioning revealed abdominal pain and stearia. Examination at this point revealed finger clubbing, shown on the pictures, prompting further investigation into an underlying chronic respiratory condition. Computed tomography chest showed widespread bronchiectasis, shown by yellow arrows, with evidence of mucus plugging. Also, it can be seen on the pictures. On the picture, sweat test revealed a high chloride level of 81 with more than 60, reflecting a likely diagnosis of cystic fibrosis. Subsequent to genetic testing confirmed cystic fibrosis mutation, and exon 14B deletion was present. Lung function tests at the time of diagnosis revealed a forced vital capacity of 73% predicted and a forced expiratory volume in 1 second of 54% predicted. There was also evidence of pancreatic insufficiency due to his low lactase level. For patients presenting with chronically productive cough, the differential diagnosis would include cystic fibrosis, asthma, tuberculosis, primary ciliary dyskinesia, immune deficiencies, as well as gastroesophageal reflux disease and recurrent aspiration. Subtle signs of finger clubbing and nasal polyps may help guide towards the diagnosis of cystic fibrosis. After the initiation of treatment, the patient's long-standing symptoms, including cough and loss of appetite, has improved. His weight and height increased to between the 9th and 25th centile. In addition, his lung function has improved. He remains under regular review at the cystic fibrosis clinic. Cystic fibrosis is an autosomal recessive disease caused by mutations in the CFTR gene encoding the cystic fibrosis transmembrane regulator. The principal defect is of chloride ion transport, resulting in high salt concentrations in sweat and in viscous luminal secretion in respiratory and gastrointestinal tracts. CFTR mutations can be severe, resulting in multi-system disease, or mild with limited disease extent and severity. Cardiopulmonary complications constitute the most common cause of death. Pulmonary infections, especially with resistant Pseudomonas or Burkholderia species, that are very frequent. Bronchiectasis and right-sided heart failure are long-term sequelae. Pancreatic insufficiency is extremely common. Infertility caused by congenital bilateral absence of vas deferens is a characteristic finding in adult patients with cystic fibrosis. Liver disease, including cirrhosis, is increasing in frequency as life expectancy increases. Molecular therapies that enhance the transport of stability of mutant CFTR protein are useful in patients who harbor certain CFTR alleles.